Hello, everyone, and thanks for joining us. A warm welcome to the 2025 American Diabetes Association's Living with Diabetes Ask the Experts series. Today's topic is obesity care, medications, technology, and tips. I'm your host, Susan Weiner. I'm so excited to be here. I'm a registered dietitian, nutritionist, and certified diabetes care and education specialist. And our Ask the Experts series is all about you and your questions and what you'd like to know. So please get your questions ready about this important topic. Please stay with us throughout the entire hour. We're going to have a lot of different discussions on different topics, answer all your questions, and bring different subjects to the table. If you have any questions, please remember to get them ready and press *3 on your keypad if you're calling by phone. An operator will collect your question and bring you into a queue, so you'll have the opportunity to ask it live if you'd like. If not, I can ask it for you. And if you're participating online, please type your name and your question into the fields below the streaming player, and please press the Submit Question button, and your question will come directly to us. Joining our program today is a great step towards taking care of your health. A big thank you to Lily for supporting and sponsoring today's Ask the Experts event, as well as the work of the American Diabetes Association to address obesity. Obesity results from a mixture of environmental, behavioral, and genetic factors. This means there are multiple ways to manage it, which we'll talk about today. Please visit diabetes.org/obesity. That's diabetes.org/obesity to learn more. Recently, the Obesity Association announced the publication of Weight, Stigma, and Bias Standards of Care in Overweight and Obesity. The recommendations are part of the standards of care in overweight and obesity and addresses the pervasive stigma in individuals who live with obesity and with overweight. And it addresses concerns around health access, health quality, and outcomes. So please go to obesityassociation.org. That's obesityassociation.org to learn more. And please share this information with your healthcare team and with anyone else that you think would benefit from it. And now I am really excited to introduce today's guest expert, Dr. Robert Kushner. We're so fortunate to have him with us today. Dr. Kushner is a professor of medicine and medical education at Northwestern University Feinberg School of Medicine and former director of the Center of Lifestyle Medicine in Chicago. After finishing a residency in internal medicine at Northwestern University, he went on to complete a postgraduate fellowship in clinical nutrition and earned a master's degree in clinical nutrition and nutritional biology from the University of Chicago. Dr. Kushner is past president of the Obesity Society, the American Society for Parenteral and Enteral Nutrition, and the American Board of Physician Nutrition Specialists, and a founder and first chair of the American Board of Obesity Medicine. Dr. Kushner has authored over 250 original articles, reviews, books, and book chapters covering nutrition, obesity, and medical education, and is an internationally recognized expert on the care of patients with overweight and obesity. He is an author and editor of multiple books. Current books include Nutrition and Bariatric Surgery, Lifestyle Medicine, a Manual for Clinical Practice, Creating a Lifestyle Medicine Center, 6 Factors to Fit Weight Loss That Works for You, and Primary Care, Evaluation and Management of Obesity, and so much more. A warm welcome, Dr. Kushner. Thank you so much for joining us today.
Oh, Susan, it's a pleasure to be here. Thank you for inviting me.
Of course. So, Dr. Kushner, this is something that we discuss so many times with our patients and clients who seek our clinical guidance, who are trying to address overweight and obesity management. Where do you start when you're trying to explore treatment options for overweight and obesity? Where do you begin?
I'd love to say begin with your primary care clinician, because that's what we're trying to educate our clinicians in the primary setting to evaluate someone and broach the topic about obesity, although there's differences in education to do so. Regarding information, you may want to start with the ADA website, diabetes.org. There are some wonderful tabs on health and wellness and tips about losing weight. But regarding treatment, it could be a primary care clinician. Registered dietitian is always wonderful resource for getting more information about weight management and diet as well.
It's a great place to start, and I know that we'll explore all these treatment options throughout today's discussion. If you're just joining us, today's topic is obesity care, medications, technology, and tips. And as a reminder, for those of you who are joining by phone, please press *3. That's *3 on your keypad, and an operator will collect your question and place you in a queue. So you'll have the opportunity to ask it live. And if you're participating online, please type your name and question in the fields below the streaming player. Remember to hit the submit question button, and your questions will come to us live so that we can ask it for you. Well, Dr. Kushner, you are popular, and we are already receiving a number of questions live. So let's get started. We have a question that is coming in from Gary, and Gary is calling from St. Louis. So Gary, please go ahead with your question.
Thanks for taking my call. My question is, I'm a diabetic and I'm overweight, and I was taking the Ozempic, and my doctor changed me to the other shot once a week. What is the Mounjaro, I think it is. And my question is, I was listening to my Alexa device the other day. They gave a medication out. I don't know if you guys know anything about it. It's supposed to help with your muscle mass loss with taking that shot. And also, I want to see if you can answer that question. And I want to sit back and listen to see how can I do to help you get some of this weight off. I appreciate this service that you guys give. Thank you.
Thank you, Gary. And Dr. Kushner, as you answer, you can see that our questions are going to come in with very timely topics.
Sure. Well, there's a lot to unpack there. So let me provide some background at the top of the hour here. Ozempic and Mounjaro, these are two medications that are FDA approved for treatment of obesity. Both of them include a hormone-like medications that we naturally produce in our body. You've heard of the GLP-1, GIP. These are naturally occurring hormones that when we make them synthetically in pharmaceutical doses and then inject them back, they have a profound effect on control of sugar for diabetes, but they also have another effect on appetite, and that's where they are also approved under different trade names for management of obesity. And they work primarily by reducing appetite, and that's how one loses weight as well as get the blood sugar under control. Going from Ozempic, which is one medication, semaglutide, to Mounjaro, another medication, tirzepatide, can be indicated depending upon how you do on one medication or the other. Often we'll go back and forth depending upon how one responds, tolerability, efficacy, and so forth. The other thing you bring up is muscle mass. And the category of these medications are now called highly effective weekly injectable medications, where individuals are losing amounts of weight we've never seen before with earlier, mostly oral medications, in the range of 15 to 20% or more body weight. You can do the calculation yourself based on what you weigh. It's often 30 or 40 pounds or more, which is really quite remarkable. But with that weight loss comes not only a loss of body fat, which is what we want, an improvement in your overall metabolic health and sleeping at night and arthritis in your knees and so forth, but you also lose something called lean body mass, which is your muscle mass. The evidence appears to show that these medications do not selectively reduce muscle mass beyond what you would lose if you happen to lose 20 or 30 pounds through any mechanism at all or any other treatment. However, if you can be at risk if you're 50 years old, 60 years old, right? Maybe don't have a lot of muscle mass on you to begin with, and you lose 15 to 20% of your muscle mass, that is a lot of muscle. So there's a whole new group of medications that are now being investigated. None of them are available over the market at this time, but it's this new wave of medications that may have muscle sparing properties. So I would envision in the years to come, whether a crystal ball is 3 years, 5 years, whatever, is that one may take a medication like semaglutide or tirzepatide, these weekly medications, along with another medication if you are at risk to help spare your muscles so you don't become weak and have fatigue. So that's in the future. But right now, in short of having those other kinds of medications, we are always recommending individuals on these highly effective medications to take ample amount of protein in their diet. That helps the building block for muscle, along with physical activity, particularly resistance training. So that's a combination. Protein in the diet, resistance training tends to hold on to the muscle so you don't become too weak or have fatigue.
That's such excellent recommendations because it's not just the GLP-1, the Ozempic, as Gary pointed out, that his doctor recommended. There are lifestyle interventions that go on this part of the treatment plan. So as Dr. Kushner mentioned at the beginning of the hour, working with a registered dietitian or a diabetes care and education specialist or someone who is a registered dietitian and certified diabetes care and education specialist can help you with your nutrition plan to make sure you're getting enough protein, vitamins, minerals, etc. When you're eating less, we want to make sure that you're eating the correct foods and the foods that can help to on your health journey. Dr. Kushner, can you speak just a little bit more before we go to our next question about the resistance exercise? We have a few questions coming in about that. How much resistance exercise should one be doing when they're on this weight loss journey and taking one of these medications?
We traditionally divide exercise into two different categories. One is aerobic activity. We're familiar with that. That would be rapid walking, being on a bike, playing tennis, jogging, roller skating, anything that we get our heart rate up and sustain for a while. That causes cardiovascular fitness and reduces cardiovascular complications. That's aerobic. The other type of category is resistance training or weight training. And that's where we're actually taking weights or using our own body to build muscle. The recommendations we use are from the US guidelines for physical activity for healthy Americans, and that is about 2 times a week. Um, I think most people can do aerobic activities on their own. It's equivalent. You pick up your dog or go with a neighbor and go for a quick walk, a rapid pace walk for 20 minutes. That'd be an example. Resistance training, however, is something not everyone has experience with. And you don't want to hurt yourself. You want to know, are you doing the right exercise? Are you using the right weights? Are you using the right posture so you don't hurt yourself? So when I see patients who don't have an experience with resistance training, I will often ask them to either watch some videos online, like YouTube videos, or if you can afford to, go to your local health club or fitness area and see a personal trainer, even a physical therapist who can give you the right form and exercises to do. And you don't need a lot of equipment. You can have bands at home with small free weights to get started. But that's the kind of exercise, resistance training, that's going to hold on to your muscle much better than aerobic activity. But the idea is you want to do both for overall health and fitness.
Absolutely. Great response. Thank you so much. We have a great question coming in from Alan, and Alan is calling us from Pittsburgh. Alan, please go ahead with your question. Alan, are you there? Well, I'm going to ask Alan's question for him. Alan asks, what is the definition of obesity and how often should you weigh yourself? I'm going to add on to the end of that question from Alan and ask what does the scale weight actually mean when you do weigh yourself?
Okay. It's an excellent question, Alan. And I'm sorry you didn't get a chance to answer it yourself, but Susan did a very good job. The definition of obesity, and there's many definitions, but they really all come down to this sentence, and that is obesity is excess body fat that can pose or does pose harm to your health. So there's two parts to it. First is excess body fat. How do we actually know if you have excess body fat? It turns out, in a very practical way, it's difficult to do that because most primary care offices don't measure body composition. Underwater weighing, bioimpedance, a bod pod, DEXA, which is often used for osteoporosis and bone measurements, can do that. Different CAT scans and so on. We don't do that in clinical practice. So what we use is a surrogate marker of excess body fat. That's called body mass index. And that it's a height and weight relationship. You can just go online now and search BMI and you'll find out what it is. So by screening purposes, a body mass index or BMI over 30 has been defined pretty much around the world as obesity, meaning it's equivalent to having excess body fat. Ideally, you would actually have your body fat measured. Since BMI has many limitations, you could imagine it doesn't measure lean mass, it doesn't measure water, doesn't measure where the body fat is located. We are now recommending that everyone also in the primary care office have a waist circumference measured along with their height and weight. So 3 measurements when you see your healthcare professional: height, weight, and waist circumference. And it's a combination of those 3 we call anthrometric measurements that we could determine if you are at risk. The more weight around your midsection, the more likely it is that your excess weight is excess fat, and it's the weight around the abdominal area that is the culprit, the one that actually is associated with more medical problems. So that's the first part of that sentence: excess body fat. The second is it poses a harm to your health. So how do you know it's posing harm to your health? One is, do you have any signs or symptoms that may be related to that excess body fat? So there'll be examples like arthritis in your knees, swelling in your legs, shortness of breath or breathlessness when you are, walking, urinary incontinence, or other conditions that your healthcare provider would measure in you, like an elevated blood sugar, hemoglobin A1C, increased LDL cholesterol or triglycerides, increased blood pressure, and a whole host of other problems. That really shows that you're having a harm to your health. So that's what obesity is. The last part of the question is how often should you weigh yourself?
Mhm.
And the answer is the amount of time that you're comfortable with. I have patients that weigh themselves every day because they don't get freaked out. They don't measure their self-worth by their weight. It doesn't color their day. They just want to use it as a measurement, like a blood pressure. What do I weigh today? And use that information. However, other people don't want to know that information that often. It drives them crazy. So for those individuals and where body weight is important to know, I'll say measure it 1 or 2 times a week. The bottom line, Susan, is that I use body weight as a metric, another measurement of one's health, just like a blood pressure, or heart rate, or looking at a blood sugar. Is one of the determinants I use when I see a patient to put it all together and determine, is this individual as healthy as they can be, and where can I help them become healthier?
Okay, you stated that so phenomenally as a data point, as not defining who you are, but as part of what is going on in your overall health. And I love how you described how often you should weigh yourself, that for some people it's every day, for some people it's once a week, for some people it's once every 2 months. It depends on the person, it depends on the individual, it depends on where you are in your treatment plan. So thank you so much for that, because so many people feel stigmatized and they get down on themselves, and they often define themselves by what the weight shows on the scale that day. So thank you so much for
Excuse
taking
me.
the time to
Can I
address
just
that.
add one comment on top of
Of
that, please?
course.
That is, if you have diabetes and you want to know if your diabetes is improving, you measure, or your healthcare professional measures, a blood sugar or hemoglobin A1C. That is the marker of improvement in diabetes. I can't imagine someone who says, I want my diabetes to improve, but you can't measure my hemoglobin A1C, and I don't want to know what my blood sugar is. I just want to feel I'm doing better. We don't do that. And treating obesity is very similar. You want a marker to see how you're doing. Now, one marker is increased energy, increased quality of life, increased functionality. My blood pressure is going down. My waist circumference is going down. One of the markers is also body fat. So, like you said, Susan, I agree completely. You never measure your self-worth by your weight.
Yep.
Use it as a anthropometric measurement, one of the multiple measures you're going to use to determine, am I on track of getting healthier, or am I not on track to getting healthier? And then you make your decisions based on that.
Such an excellent point. Thank you so much for explaining that, and for continuing to promote the health and the mental health of your patients as well, which is exactly what we're trying to promote. We have a great question coming in from Maureen, and Maureen is calling us from Illinois. Maureen, please go ahead with your question.
Yes, thank you. I'm a type 2 diabetic, and I've been taking Ozempic. It'll be 2 years this October. Since I've been on the Ozempic, I feel that my vision has been deteriorating. For example, I can't really see the closed captioning on the TV as well as I did before. Signs. I've been to an ophthalmologist 3 different times, and all I get is that, I have severe dry eye and corneal dystrophy. And I know I've read some articles that state that Ozempic can affect vision, and I wonder if you could speak to that, please.
Yes, thank you. That is a new finding. I've been involved in a lot of the research, not with Ozempic, but with the same medication that's FDA approved for obesity, which is called Wegovy. So Wegovy is a higher dose of Ozempic. So I've been involved in that in multiple trials, looking at side effects and tolerability and adverse events, serious adverse events, and so forth. And we didn't see any of the eye problems in the studies that we've conducted. And for that reason, we have post-surveillance studies, because you can never make all your decisions based on a select group of individuals you do the studies on. So it's really out of these post-surveillance surveys where there's a larger number of individuals who are using this drug, we are seeing that a rare, although still, I think, undetermined how often, but a rare disorder of the eye, primarily in individuals with diabetes. I don't know much more about it at this point, other than recommend, sounds like you've already done, is to see your ophthalmologist. Now, you don't want to see an optometrist for that. You want to see an ophthalmologist, which is a medical doctor of the eye, who can actually take a good look at your retina. Now, you also know, of course, as time, vision does change. Like I'm using readers as example because I'm aging, but really staying close with your ophthalmologist to make sure you're not developing any retinal problems, which apparently can occur with these medications, although rarer than some of the other complications we've seen or side effects.
Really great advice. Thank you. Let's go to one of our online questions, which is one just came in from Tony. We have so many different questions. We're going to get to as many of them as we can. Tony asks, what's your opinion of home body composition scales? Are they accurate?
Yeah, so that is a great spillover question from what we were talking before about body composition measurements, where they're not commonly done in your primary clinician's office unless you happen to see an obesity specialist, in which they're done much more often, particularly done as bioimpedance. The home measurements of body composition are usually bioimpedance or bioelectrical impedance, which you're standing on the scale. And although you don't feel it, there is a current that's actually electrical current that's going through your body and being carried by the electrolytes in your body. And using equations based on how much you weigh and putting other information in that, it will estimate your body water, your lean body mass, and your fat mass. So, from a rough point of view, I think it's okay. A few caveats, though, you need to know if you're using these scales. One is the measurement conditions are extremely important to know, so that if you exercise heavily or become dehydrated and get on the scale, the measurement is going to change dramatically because you've changed your body water. If you're wearing socks, it won't work because it has to have conductivity directly through your skin. If you have a lot of calluses on your feet, it's going to change that conductivity. Time of day probably has an effect. So if you measure after you had a large dinner, you're going to be measuring some of that in your gastrointestinal tract, and it's going to reduce your body fat. So there's a lot of variation in it. So what I would recommend, just knowing that, is if you're going to do body composition measurements at home, these body weight scales using bioimpedance analysis, have a standard measurement condition every single time you weigh yourself. Typically, for an example, first thing in the morning after you go to the bathroom, you haven't eaten yet, you're in your pajamas, and you're standing there with your bare feet, and that's your measurement condition. And you repeat that every single time. Second of all, the actual measurement you're getting may not be terribly accurate, but the trend you're getting is likely to be helpful. So if you're on a weight management program and you want to track your journey, whatever program you're using, and let's say you're weighing yourself once a week, that trend in changes in body fat, I would be more interested in than the actual measurement on a day to day.
Great point. That's a really great point. Can you speak just a little bit more about that by what you mean by trend? Because I know that that's going to come up in questions. That's an excellent, excellent point.
Well, we already, Susan, you and I already talked about how, weighing yourself, which basically is your weight, which is your bone, your fluids, your muscle, your fat, and everything else.
Everything
I,
all together. Yeah.
Everything all together is what you're weighing, and that's what you get. When you're doing a body composition measurement, it takes different variables, your weight and height and age and gender, because that's the equation that's used, and it will tell you what your body fat percentage is, or your body fat in actual pounds. And you're looking for, if you're on a weight loss journey, not only are you looking for your weight to go down, but you're looking for the percent of your body fat to go down. So let's say at the beginning of your journey, the bioimpedance measurement says you have 35% body fat. And that would be high for a woman or a man. As you're losing weight, that percentage should be going down 33%, 30%, 28%. If, however, you're on some program that isn't particularly healthy and your body fat percent is really not going down, that means you're losing excess amount of lean mass or muscle mass, and that's not good. So it's another way of tracking what you're doing.
Excellent. Thank you so much. Appreciate that. Let me go to another online question, and so many great ones are coming in. And Jan writes, I've been on Ozempic for diabetes for about 8 weeks. In the last 2 weeks, getting horrible hot flashes, which are new. Does Ozempic cause hot flashes, and how can I remedy it? Should I be on a lower dose, or should I lower my dose?
Yeah, I mentioned before that I've been involved in the studies of semaglutide or Wegovy, not the Ozempic trials, but as I said, it's the same drug. We really didn't see any reports of hot flashes from the medication. However, I can tell you that as you're on this drug, there are other symptoms that can occur: nausea, vomiting, diarrhea, constipation, heartburn. Particularly if one has diarrhea, has a change in fluid balance, I could potentially think it may lead to different feelings, maybe like hot flashes. We also know that a woman's menstrual cycle will depend in part on body fat because it has different effects on estrogen. But I really don't know what would be causing hot flashes in your case. I really would recommend you talk to the prescriber and let them know what you're feeling. When I see a patient, I don't understand the side effects. I'll often reduce the dose to see if there is a cause and effect. Sometimes I'll even stop a medication, but I'm not sure I'd need to do it in this case. But I would talk to your prescriber and see whether changing that dose may have an effect.
How do we start a conversation with our healthcare providers, our physicians, nurse practitioner, PA, diabetes care and education specialists about addressing obesity and maybe using some of these technologies to help with some of our treatment options? How do we start that conversation, and how do we prepare for them in our visits?
Yeah, I love that question. I'm so glad you brought that up because now we're going upstream, right? Upstream to that initial conversation before you get even into all the medications and lifestyle management issues that we were just talking about. In many offices, it's a don't ask, don't tell situation, right? You
Mhm.
know you're overweight. Your healthcare professional knows you're overweight. Don't ask, don't tell. So like it's not even discussed. We clearly need to move beyond that, and I would empower you to bring up that conversation with your healthcare professional if they have not. So you can broach a topic. It says, I have been aware of my weight. I know my weight is affecting my blood sugar or my diabetes or my blood pressure. I tried on my own. It's been very difficult. I've lost weight, I've regained weight. I really need more help. And I would like your assistance in helping me better manage my weight. Now, that's how you can approach it if your healthcare professional doesn't. In addition, though, I would encourage you to be prepared with more information. So, for example, have some body weight measurements that you can bring in and show your healthcare professional. You even may want to track your diet. using a food tracker on your phone. Most of them are free that you can do. And track your diet for a few days to get an idea of what your meal and eating pattern is. These trackers also will look at calories, carbohydrate, and protein. You can track your water. You could also get an idea of your physical activity by using, again, your smartphone or another digital wearable device to see how many steps you're taking every day. So you can actually go in there, be empowered, not only to bring up the conversation, but hey, I have data, I have information because I have already begun the process. I'm preparing for an intervention, my physical activity, my diet, here's my weight, and see what they do. Now, if they're not prepared, competent, or have the familiarity and want to get involved, you can always ask to see a registered dietitian. You could always go to an obesity medicine specialist. You can join a commercial program that also provides that kind of care. There's many places you can go. And just let me just add one more thing. Let me put, instead of the hat on of the patient, let me put the hat on of the professional. And you mentioned earlier that I'm a professor in the Department of Medical Education as well. So I spend a lot of my time, along with my peers, to educate primary care clinicians on how to broach the topic up with their patient.
Excellent.
And this is what we tell them: ask permission. And it'd be like this: I've noticed that your weight has been climbing for the past year. We've been working on your blood pressure or arthritis. Weight can be a factor in your arthritis or your blood pressure. Is this a good time to talk about your weight? Would you like to
Wonderful.
talk about your weight? So we do it as a way of permission. The other thing we're trying to educate primary care clinicians to do is to do a weight prioritized visit. What we hear all the time from medical professionals is everything else I'm trying to do is getting crowded up. Before I do the vitals and I do medication reconciliation, we go over, what's bothering you today. There's no time left in the visit to talk about body weight. So we're trying to shift to a weight focused or weight prioritized visit. So when you come in, that is what we are going to talk about. So you are prepared as a patient, and I am prepared as a healthcare professional to zero in on getting the treatment started so you could take better care of your weight, and we could bring in other resources if needed.
Just fabulous. And it's scheduling a separate visit for a weight focused visit to address those concerns. That's excellent.
Correct.
Really a great suggestion. Let's go to a question that a few people are asking. So I'm going to have Elizabeth ask it. And Elizabeth is calling from my home state of New York. So Elizabeth, please go ahead with your question.
I'm calling to ask, good afternoon, everyone. I'm calling to ask, is Manjaro and Ozempic the same as Trulicity?
Very good question, Elizabeth. It's the same category of medications. They're called incretin hormones, or, they mimic these gut hormones that we produce, GLP-1, GIP, those. And then pharmacologically, we give it back to ourselves on a weekly basis. So it's the same category. It's like taking different blood pressure medications. These are different medications in the same category, but the actual molecule or the drug itself is different. So Trulicity is taken once a week, but it's dulaglutide. It's very effective for diabetes, but actually not as effective for weight management. Ozempic is called semaglutide, and then Mounjaro is called tirzepatide. So they all mimic these gut hormones, but in different dosages and different combinations. I think the bottom line, Elizabeth, and everyone else who's tuning in, is you want to have a medication prescribed to you that is best for you. There's no one best medication. Some individuals do very well on Trulicity, others do well on Ozempic or Wegovy, others do well on Mounjaro, or the comparison drug to Mounjaro that's approved by the FDA for weight management is called Zepbound. So I don't want to overload you with trade names, but they all have these different names and different molecules within them. And that is important for you and your clinician to have that conversation. The bottom line, though, which is sad, is that the decision on which medication, at least currently in the United States, is mostly driven by cost, accessibility, and what your insurance covers. So I may think you're a great candidate for Zepbound, which is approved for diabetes, but your insurance only covers Trulicity. So we're going to use Trulicity. That's hopefully going to change to make all these compounds, these drugs more available, so we truly could pick the best medication for you without having to worry about what's covered by your insurance.
Excellent. Alice has been waiting very patiently with a double question online, which I will ask for Alice. Alice asks, what are the side effects of Ozempic? And I'll add the GLP-1 medications. And at what point is Ozempic recommended for obesity?
Okay, so I was just saying a moment ago to Elizabeth that all these drugs are in the same category called incretin-based medications. That's what we call them medically. And even though they are different molecules, different drugs, and so on, they all have the same essentially side effect profile that are all in this big camp called incretin-based medications. And they are primarily gastrointestinal side effects, most notably nausea, diarrhea, constipation, vomiting, and heartburn. And some people also get some fatigue. The frequency varies from person to person, but the categories are about the same. Just how often you get them changes. By doing these trials, we learned a lot on how to lessen these side effects when you start these medications. And what we always do now, based on these trials, is one, start at the lowest dose for that particular drug and slowly escalate, usually every month. So these drugs are generally given as a self-injection once a week. So you give 4 injections, you then go to the next dose for 4 more injections, so that you're dose escalating every month. That's what we learned. You should never start at the highest dose. You'll be very, very sick. So that's the first thing, very, very important to do, is start slow and go slow. If you're having a side effect, your prescriber will probably hold that dose where it is before they further escalate. That's number one. Number two, we learned through these trials, in addition to slowing the dose escalation, is to pay a lot of attention to the diet. Diet has a large role to play in whether you get these symptoms or you don't get these symptoms. So the specific recommendations we have for all patients on these medications is one, do not overeat. Know what is in your diet. When you start feeling full, stop eating. Number two, the quality of the diet. Make sure your diet is not overly greasy, high in fat, or highly spicy food. That tends to make it worse. Number three, have a game plan. You don't want to go long periods of time during the day not eating and then finally say, oh, gee, I missed lunch and I didn't have any snacking. Now I'm going to eat dinner. You're likely to get sick. So have a plan in place in your mind of what my diet is going to be as the day unfolds. So that helps, and keep hydrated. Let me add that as well. So by slow dose escalation, have a plan regarding your diet, you can significantly reduce those GI side effects that I just talked about.
Excellent. And it always goes back to even with using these medications, we have to be healthy, eat well, be physically active with the aerobic and the strength training exercise, get plenty of sleep. And of course, as you mentioned, adequate hydration, drinking your water and eating plenty of fiber as appropriate. So let's go to another question, which is coming in from Alexis. Alexis is calling in from Seattle. And Alexis, please go ahead with your question.
Oh, hi, and thank you. My doctor's prescribed Ozempic, but I've seen a lot of reports of gastroparalysis, and so I've been really leery about taking it because that's a permanent condition, correct?
So, Alexis, all these medications, we can kind of group them together, slow the movement, or we call the motility of the gastrointestinal tract. So the stomach will move a little slower. Sometimes the intestines move a little slower. We think that's why some individuals get constipation, for example. And that's probably why people get heartburn, because the stomach is not emptying very well. So we see that across many of these drugs. There are some individuals, however, where the stomach really slows significantly, and that term is called gastroparesis, where the stomach just doesn't empty very well. So you end up with more vomiting or nausea. Individuals who would be high risk for having that would be individuals with long-standing diabetes, people with diabetes type 1, people with scleroderma, and other GI conditions. We have to be very careful to give it to them. It is not common among the general population, but nonetheless, there are individuals who are at risk for that. And my recommendation is to talk to your own healthcare professional who's the prescriber and ask them, am I a candidate for having gastroparesis? Is there any reason I should be at higher risk of having gastroparesis beyond other individuals?
And I know that some people who have a very precipitous drop, a very quick drop in blood sugar levels, and some of you listening today may have experienced gastroparesis, which is a concern. So as Dr. Kushner is recommending, that is something to discuss in your individual care plan and in your treatment plan with your physician, and to make sure that they're aware of any changes that you may be having in your health status or how you are feeling. So that's really important.
Susan,
We have
Susan, let me
sure.
just, Susan, can I add something?
Oh, sure.
Is that this whole slowing of the gastric movements, that is the reason why the American Association of Anesthesiology came out with a recommendation to hold medications like Ozempic or Mounjaro a week or two before a procedure that would require intubation or endoscopy to make sure your stomach is not moving too slow. So that's just a good point I want to make out. So if you are having any procedures that are coming up, make sure you talk to your healthcare professional about when should I hold the dose? How many
Yes.
weeks or days should I take my last dose before having that procedure?
Absolutely. And in many cases, before having a procedure, before having anesthesia in particular, it might be around 2 weeks. So that's a very important discussion to have with your healthcare professional. Great point. Thank you for sharing that. And I'm not sure if this is a question coming in online from Ethel. I'm not sure if we can recommend a particular brand, but maybe a type. Ethel asked, do you recommend a particular home scale?
I don't. I do know there are, it pretty much what you're looking for. If you're looking for a scale that does body composition, like an earlier question, there are certain companies that particularly make the bioimpedance scale. And if you're not looking for that, there's probably many other scales. I think the one thing I do want to say is that if you're going to weigh yourself at home, it is very important that you use a hard surface. Don't ever put your scale on carpet. Make sure it's a hard surface like in your bathroom. And we already talked about the measurement conditions, right? You have to go to the bathroom, same kind of conditions every week. But as far as the brand, I really don't have a recommendation.
Yes. And I don't either. So I was interested to see what you would say with that. Great point. You want to make sure it's on a flat surface, or else it's not going to be accurate at all. Let's go to another question. There are so many coming in online and on the phone as well. So another one that's coming in online is from Christine. Great question. Is it true that many people eventually regain weight even when they stay on the GLP-1 medications? If so, is it a temporary weight loss worth it in the long run?
It's a good question. There's a lot to unpack there, and let me address some of the issues I think that are important to know. Before, Susan, you had asked, I think on someone's behalf, what's the definition of obesity? And I said it's a excess body fat that either poses or has a risk harm to your health. I left out an important phrase there, though, and that is it is a chronic, recurrent, progressive disease, just like diabetes is. Once you have diabetes, you could put in remission, you can control it, but generally you have diabetes regardless of what your hemoglobin A1C is and so forth. And if you stop taking a medication or stop your active healthy eating pattern or your physical activity, its chances are your blood sugar is going to go back up again. And I wanted to start with that comparator because that is how we think of obesity. Just like diabetes is chronic and progressive and recurrent, obesity is the same thing. So it has a risk of reoccurring if you stop the treatment you've been doing. So if you're on an incretin-based medication, semaglutide or tirzepatide, and you have a 15 to 20% weight loss, if you say to yourself, I got this now, thanks, doc, I'm on my own, stop taking the medication, a very high likelihood your weight is going to go back up, just like your blood sugar would go back. Same idea. But the question specifically is, if I'm on a medication like Ozempic, will your weight go back up even on Ozempic? And most of in fact, all the information we have, which now goes out to 4 years on these medications and carefully controlled studies, we don't see weight recurring as long as you stay on the medication. Or maybe slow bumps up in your weight for a variety of other reasons, one of which you're getting older. But we don't see the weight recurrence if you stay on the medication. It's if you stop the medication, just like you would stop your diabetes medication, the disease is going to come back. So anyone who's on a medication for obesity, whether it's these new highly active incretin hormones or some of the earlier medications, you really need to think about long-term use.
Yes, that was a great comparison. Thank you so much for that. This has been an incredible discussion that we're still continuing as we recommend scheduling a visit with your HCP to focus on obesity management. As Dr. Kushner suggested, that can be a separate visit to address your concerns so that you can set realistic weight loss goals, learn about treatment options available to you. So very important. And ask for appropriate referrals to a registered dietitian, nutritionist, to a certified diabetes care and education specialist, a physical therapist, a mental health professional, whatever points that you think need to be addressed, that has to be addressed, and it has to be in collaboration with your healthcare team. And so with thinking about all the questions that we're talking about today, and there have been some excellent ones, Dr. Kushner, what other final points and takeaways would you like to bring to light for today's discussion?
Thanks, Susan. First of all, thank you so much for having me. And these are just outstanding, wonderful questions that hopefully will empower all of the viewers and listeners to help them take better care of themselves. I want to reinforce some of the information we went over with. If we go upstream, make sure that you either you broach the topic with your healthcare professional, or hopefully your healthcare professional broaches the topic with you. Take advantage of that. Number two, being overweight or having excess body fat is not your fault. It is a biologically driven chronic condition in which there are multiple treatments available, starting with lifestyle management, diet, physical activity, behavior change, working up to pharmacotherapy. We had a lot of questions about drug treatment and also even bariatric surgery, which we didn't get a chance to talk about. Lastly, it is a team sport. It's not just about you and one other person. If you need more help with your diet and eating pattern, need more help with your mental health or mood, more help with physical activity, ask for a referral to focus in on those particular areas. Lastly, it is long term. So you're talking about changing your behavior, changing your attitude, changing your goals with long term plans in mind.
And if someone wanted a referral to someone who was a physician in bariatric care, in obesity management, where do they find someone as wonderful as you are? Maybe not everybody can find, but where does someone look for someone who particularly specializes in obesity care management?
You mentioned that I was a first chair in the American Board of Obesity Medicine, which is a certifying body for obesity medicine specialists. So that's where you can go. You go to ABOM, American Board of Obesity Medicine. So abom.org, and you'll see a across the top a flag that you could actually click on that will identify diplomats of the American Board of Obesity Medicine in your area, I believe by either city or zip code. So abom.org.
That's really great advice. I know that we had a couple of questions about that as well. And if you are looking for a registered dietitian nutritionist, you can also go to eatright.org. That's eatright.org to find a registered dietitian in your area if you get a referral as part of your care. And also if you're working with people in a practice who are specializing in obesity care and medicine and management, they can also refer you to some of the people in their practice who specialize in different areas. Dr. Kushner, you were absolutely amazing today. Thank you so much again for being here for this presentation. We appreciate you and all you're doing. Remember to talk to your doctor. You're very welcome. Talk to your doctor and members of your healthcare team about obesity-focused visits and options available to you. Remember to go to diabetes.org/obesity. We had a couple of questions today about where to find out more information. That's the part of the site that will help you on the ADA site. Register for our next event at diabetes.org/experts and sign up for diabetes education classes near you. Please call 1-800-DIABETES. That's 1-800-342-2383 or email askada@diabetes.org to request a digital copy of How to Thrive resource, which can help you on your diabetes journey. Thank you so much for all the questions that you wrote in with. Please stay for our very brief, less than 5-minute survey that's coming up next, 6 short questions. Your feedback is so important for us to shape future events. So please, what you think really matters. I would really appreciate it. The ADA would really appreciate it if you can take the survey. If you have any questions about this event, you're welcome to contact us at askada@diabetes.org, or again, call 1-800-342-2383. And again, the Ask the Experts events are available on demand at any time. This one will be up in a few days at diabetes.org/experts. Thriving with Diabetes takes a team, and we are all here to support you. A very special thank you to the amazing Dr. Kushner, who joined us today. My name is Susan Weiner, and on behalf of the ADA team, we want to thank you for joining us today and look forward to connecting with you for our future events. The next one is on October 14th at 2 p.m. Eastern Time, Breaking Down Barriers, Why Advocate for Obesity Care and How. And on November 11th at 2 p.m. Eastern Time, What's on the Menu? Nutrition Strategies for Obesity Care. You can register free for both live events at diabetes.org/experts. Please visit our website for more information and register today. And if you have any questions, again, reach out to askada@diabetes.org. Thank you so much for participating in today's event. Let's begin today's survey. Question one. This event met my expectations today. Question 1. This event met my expectations today. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. This event met my expectations today. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. And if you feel you can use some more support for managing your diabetes, please check out diabetes.org. The entire website is built for you, and there are lots of links to information that can help you on your diabetes journey. Okay, question 2. I will attend another Ask the Expert event. Question 2. I will attend another Ask the Expert event. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. Question 2. I will attend another Ask the Expert event. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. Anytime you want more information about obesity management, please visit diabetes.org/obesity. As we saw in today's presentation, you are not alone. please check out diabetes.org/obesity for more information. Question 3. This event improved my knowledge of obesity care, medication, and technology. Question 3. This event improved my knowledge of obesity care, medications, and technology. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. For yes, press 1. For no, press 2. And if you're unsure, please press 3. Did you know that there are approximately 38 million people living with diabetes and you are not alone? If you're looking for peer support, the ADA for Peer Support is available in local state offices, diabetes camps, online forums, and more. Please check out diabetes.org/community for more information. We're halfway done with the survey. Thank you for taking it. Question 4. Question 4. I intend to use my knowledge that I gained from my and my loved one's next appointment with a healthcare professional. I intend to use the knowledge I gained from my or my loved one's next appointment with a healthcare professional. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. We need to check out nodiabetes.org to learn more on how to reduce the risk of heart attack, heart failure, diabetes, and kidney disease. Okay, let's move to question 5. Before this event, I felt confident talking about obesity care, medications, technology, and tips with healthcare professionals for myself and my loved ones. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. Before this event, I felt confident talking about obesity care, medications, technology, and tips with healthcare professionals for either myself or my loved ones. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. There's so much to know about taking care of your health and living with diabetes, and it can be overwhelming. If you want to find out more strategies and tools for diabetes burnout and mental health, please visit diabetes.org/health and wellness to get more information and support. And let's move to our next and last question, question 6. Question 6. After this event, I feel confident talking about obesity care, medications, technology, and tips with a healthcare professional for myself or my loved ones. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. Question 6. After this event, I feel confident talking about obesity care, medications, technology, and tips with a healthcare professional for myself or my loved ones. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. We sincerely appreciate your time and look forward to engaging with you on a future Ask the Expert event. Please visit diabetes.org/experts to learn more about upcoming events. I'm Susan Weiner, and I appreciate you joining us today. Thank you so much, and looking forward to seeing you on our next event.